what is stressful for one person is not stressful for another person.
Welcome to the Stress Navigation Podcast. In this podcast, we'll talk about stress, science, and daily life. We'll interview experts in the fields of psychology, psychiatry, physiology, genetics, sociology, data analysis, and much more. I'm Marco Ros, and I am the host of the Stress Navigation Podcast, and today we are talking to Brenda Penninx, a professor of psychiatric epidemiology of the Amsterdam UMC. Hello, Brenda.
Hey, thank you. Nice to be here.
Yeah, thanks for being here. We have a little intro. She is an international expert in mental health research, integrating psychiatry, psychology, neuroimaging, genomics, endocrinology, sociology, and behavioral medicine. She has published extensively, and she has been within the top 1% of the highest cited researchers in the field of psychiatry. She's a big proponent of cohort studies and has initiated large multi-site projects like NESDA, the Netherlands Study of Depression and Anxiety. She's also vice president of the Royal Netherlands Academy of Arts and Sciences, and just last year she launched the 10-year project called Stress in Action, which is why we have her on the show today. This is the Stress Navigation Podcast, and we're doing it under Stress in Action's wing. And we could say much more about her. As you can see, she has an impressive career, but we're just very happy to have her here. She's also my PhD supervisor. So yeah, thanks for joining us, Brenda. How's it going? How does it feel to hear a summary of your career just laid out like that?
Well, I think you got a good image of who I am and what I've done so far academically. So
nice to hear.
I think that's me.
Well, yeah, I guess just to dive in already into the topic. Well, you're an expert in mental health research. And we would like to hear your take on the current state of mental health in the Netherlands, in the world, if you're aware. Yeah.
Yeah, well, I can say a little bit about it. Well, indeed, since the last 20 years, my work has mainly focused on depression and anxiety disorders. And there are several reasons why I really think that this is really an important topic for society, but also for research. First of all, we know that depression and anxiety disorders are the most common mental disorders in the Netherlands, but also actually worldwide. Mm-hmm. And they have a huge impact on our society. I mean, if you look at the World Health Organization's listing of diseases with highest burden on society, then depression and anxiety are always in the top 10. And actually, depression is supposed to be the number one disease with the highest impact on society in 2030. That's really soon. So there are lots of reasons why we need to focus on depression and anxiety disorders. And another reason is really that I think if you compare it to some other health concerns that our society faces with, like cardiovascular disease or cancer, if you just compare the amount of research that we dedicate to mental health, that's really not as much as we do so to some other diseases. So we actually we have to catch up. We have to do a lot of research to really be able to better understand these conditions, but also better treat these conditions. And that's why, I think this is really a very relevant field of research with clear implications for society. Just think about the fact that depression and anxiety disorders are being experienced by 1 out of 5 persons during their lives. So, everybody listening to this talk will have persons that they know that have faced with either depression and or anxiety disorders. So they're really common. And I think one trend that is disrupting, for me at least, is that despite the fact that we know this, we haven't really been able to change the impact of these disorders in the last 2 or 3 decades. In fact, there are some alarming numbers that more recently these disorders actually are even more common. Mm-hmm. So I don't know whether that's enough evidence for why, and also my feeling is that this is really an area where we could and should have more impact.
Yeah. Well, now you say, like, if in decades it really hasn't changed the situation when it comes to, I guess, number of people who have depression and anxiety, why do you think that is?
That's a really good question, but also a difficult question to address. So I think if you compare the pictures of the impact of depression and anxiety disorders to pictures that we know, for instance, also the World Health Organization is looking at these trends over time, then we observe that, for instance, the burden by cardiovascular disease, for instance, we have been able to change a bit and reduce a bit over time. The same is true for the impact of the burden of a condition like cancer. So if you look at the impact of depression and anxiety disorders over the last 2 or 3 decades, we do not see a decrease in the burden of these conditions. And I think there are multiple reasons. First of all, I think there is still a lot of what we call a huge treatment gap. There are still lots of people, even in westernized worlds, that suffer from depression and anxiety disorders that do not get treatment. And we know that the percentage of people with severe depression and anxiety disorders that are not getting treatment is about 50%, even in Western societies where, you know, there is quite adequate access to mental health care. So that is one reason. But I also do think there are other important factors. First of all, the ability to really treat these conditions is still limited. We have adequate interventions, we have antidepressants, we have psychotherapies, and we know that in populations they work. So meaning that if you treat people, then overall you see a reduction of symptoms over time. But we also know that these treatments are not miracle interventions. They work for some people. They work to a modest extent so that there still remain quite of symptoms left even when people are receiving treatment. So they are not often leading to full recovery. And I think something that we are not dealing adequately with is the chronicity of these conditions. We often consider these conditions as being episodic. We treat an episode and then people are okay. Whereas if you really look at the long-term impact of these conditions, they are quite chronic conditions. And I think that is something we are not we're not facing enough as a society and as a healthcare setting. Just to give an example, in the Nesta project that you introduced, we have followed people with depression and anxiety disorders for over 6 years. And we really see that the majority of people with these conditions, despite the fact that they are being treated during those 6 years, half of them has chronic episodes. So symptoms, unfortunately, very often come back. So we really need to pay much more attention, I believe, to relapse prevention and also adequate monitoring of these vulnerable people.
Mm-hmm. Well, there's something that I really like what you said that I would like to point out about recovery and the chronicity of the disorder. Yeah, I do feel with depression, anxiety, or with mental health issues, it seems like a lot of people would say, "Oh, just get over you. Once you get over it, it's done," right? But then there's really nice literature about recovery that considers it as a lifelong journey, and that even like I know people even have schizophrenia or mania who consider themselves recovered, even knowing that they might have episodes in the future. But you know, the whole idea of recovery is that they can live with the vulnerabilities, with, you know, knowing that it might happen again because life will just be that way.
Yeah.
But then dealing with it as a lifelong thing can definitely help us, just be more sensitive to it and help people along the way, because it's a journey.
And prevent that worsening of episodes truly have huge impacts. Fortunately, you know, this is not, the chronicity is not present in all people, so there is huge variability. And there are people that have experienced a certain episode and then they are recovering very well and, you know, continue life in a healthy state. But there is huge variability, and unfortunately for lots of people, this sometimes can really be a struggle for life. And I think that is something we need to be aware of, and also set our healthcare system up for to deal with a more chronic monitoring and chronic support of people to prevent the recurrence of episodes.
Yeah, support is the key word, I think, here. Do we know why people sometimes, like, or is there research done on why people get over it and then live a happy life, and why people have a more chronic experience of it?
Well, that's a very good question. That's really one of the key questions that we look at in the Nesta project, to really see, can we predict who's doing well and who's not doing well? It's not very simple, I have to say. I mean, there are obviously clinical characteristics that determine whether or not people recover. So, for instance, if you have very severe chronic episodes to start with, that is usually a prediction factor of a poor course. But also genetic vulnerability will add to it, and very importantly, the psychosocial environment where a person lives in adds a lot to that. You know, having a supportive environment, having a supportive partner relationship, for instance, having a stable family situation, those are known to be factors that are protective for a poor course. So that is really the evidence that we have, that it's not just one factor that you can deal with and then, you know, you can change the course of depression. It is really a complex condition where lots of psychosocial but also biological and genetic factors really determine the impact the condition has within a person and also determine the course.
Yeah. Well, I guess what we're talking about is that everything plays a role, right? How your body operates, how you are in your environment, how the environment, you know, happens and treats you, people, situations. And I guess that's why you started a project like Nesda, right? Where you follow people over time to incorporate that chronicity of the aspect, and you incorporate many variables. So would you mind telling us a little bit more about, Nesda and how it came to be and when the idea started?
Yeah, so this is a study that started in 2004, so 20 years ago. It's a long trajectory already. And the essence of the project is that we have quite a lot of studies that examine the etiology of depression, that look in general population-based studies and examine what are risk factors for developing depression. But we wanted to take it further. We wanted to learn more about the course of depression and also anxiety disorders. So I think the uniqueness of Nesta is really the longitudinal course in which we follow people with depression and anxiety disorders. And I think it's also unique that we focus on both depression and or anxiety disorders. And that's really because the comorbidity between these conditions is huge. Actually, from Nesta, we see that about 80% of persons with a depression disorder also has an anxiety disorder, and vice versa. It is very adequate, I think, to examine these conditions in concert because they impact on each other. We also know that people who have both disorders, for instance, have a poor course. So it makes lots of sense, and I think it's even necessary to study them both in concert. And the main question really is, what is the course, and can we distinguish between people with poor course and good course, and what does that tell us about the pathophysiology of depression, treatment response? Are there subgroups of people that we can identify with different pathophysiology that have a different course? So it's a very broad, I consider it a research infrastructure. And over the last 20 years, there have been more than 400 researchers using data from the Nesta project. And it's really set up as a multidisciplinary research infrastructure. So we collaborate with people interested in neurobiology, in genetics, in mental health, but also somatic health, psychology, sociology, philosophy. So I think we know the nature of mental disorders are really multidisciplinary. There are lots of, like I just mentioned already, psychosocial, biological factors that impact on both the etiology as well as the cause. So if you really want to understand these complex disorders, you really need to do interdisciplinary research.
Yeah. Did you expect 20 years ago that it will last for 20 years? Or has it been
No, I had no clue. Actually, I came back from America to lead the Nesta project. And at that time, this was 2003. Nesta was just, a 20-pager. I mean, it was a research application that was granted, right? So that's the only thing we had. I had no clue how long and how important this study would turn out to be.
Yeah, well, now you mentioned America. I'm curious about your journey, your career. What did you study?
You mean
bachelor's,
university?
yeah.
Okay. At that time, it was I studied health sciences in Radboud University in Nijmegen, and which is now called biomedical sciences. It's I think the same education still. They switched names, and I have always been very interested in the epidemiology part of that, and that has been my trajectory. So that was my thesis topic, and since then I've continued doing a PhD in the field of epidemiology. I started working mainly in the field of aging, geriatrics, but also in that field I was examining mental health and especially the interaction between somatic health and mental health, which is really one of the core themes of my career. I went to the States to spend time at the National Institute of Aging, also continuing my work on the interaction between mental and somatic health. Spent a few years at the university in North Carolina, and then I came back to basically lead the Nesta project. That was the reason why me and my husband, and at that time we added 2 kids, came back as a family.
Oh, nice. Well, I also think that this field, psychiatry, health, requires like a certain sense of sensitivity, right, towards the world, to other people. And I was just curious, when did you notice that sensitivity grow in you?
Well, like I mentioned, I'm really aware of the multi-components that contribute to mental health. And I think it's a very one-sided view to think that we can only understand that condition from genetics perspective or from neurobiology perspective. And I think that's where there is sometimes also confusion and miscommunication in the field by experts who only look at one aspect of the pathophysiology of depression. And I think it is a strength, that is how I have seen my role also being trained as an epidemiologist. As an epidemiologist, you're trained to have a broad vision and look at multiple aspects of mental health conditions, for instance. And I really have been able to utilize that in my research. And I've always really enjoyed learning from other disciplines and integrating their views in a Nesta project, for instance, to make it interdisciplinary. And I think that reduces at least some of the sensitivities. I think the sensitivities are exactly arriving when people have a one-sided view on what mental health is. And I try at least to be open and incorporate multiple angles and multiple disciplines into mental health research.
Yeah, so you always felt that there was something more than maybe just the direction. Yeah. Well, was it always the case, or like, because when I did my degree, I did biochemistry, right? And I also felt that maybe it was very molecular, very directed, and I needed to take that step back and look at a broader perspective. And I did come across a field that now does feel that we need a lot. We need multidisciplinary approach. We need a lot of perspectives. Was it the same case for you, or did you have to kind of like make your way through the field and kind of stand up and say, guys, we need to pay attention to more things?
No, I think from the Nesta perspective, we have always been very open, and we explicitly have set up the project as a collaborative project. So we have always incorporated other research groups. And this is really, I think, an advantage of multi-site cohort infrastructures where from the beginning on you collaborate with other disciplines and you really make it a shared project. So I have never really felt that tension, but we have explicitly embraced that multidisciplinary perspective.
Yeah, and I guess this experience is what then led you to Stress in Action, right? Which I also want to talk a little bit about now. Yeah. It's also a multi-site project, 10-year long, funded, and with a lot of disciplines. So I would like to know more about Stress in Action. What's the project about?
Yeah, that's another really recent project that I'm very excited about. So Stress in Action is the project that was funded through the accreditation call by the Scientific Dutch Organization and sponsored by the Ministry of Health in the Netherlands. The uniqueness of this project is that, like you mentioned, it's 10 years, so it's really long for a typical research project. And it involves lots of academic institutes. We collaborate with 7 universities with 25 very different experts in some aspects of stress research. And it involves 20 million euros. So it also gives us really a good startup to really spend adequate long-term investment in stress research for the next 10 years. The focus of the project is in the topic of stress in daily life. And this, I think, is really a unique topic. Obviously, we're not the first group studying stress. There are lots of stress researchers also in the Netherlands, but also abroad, that, for instance, have examined to really detailed expands what the impact is of acute stressors on a person's body, for instance. So what is the response of humans on acute stress? And that can be the response in terms of biology, can also be a response in terms of affect or cognition or behavior. And that has been shown that, people, when exposed to acute stress or when undergoing stress tests, for instance, in lab settings, they really show lots of responses in the affective, the behavioral, the cognitive, and the biological response of their body and mind. So I think we quite well know that stress does a lot to us as humans. However, I think a very big and more difficult question is, how does stress then occur in daily life? What during a regular life where, there is stress exposure or stressors experience 24/7 in very different contexts? What is stress doing to an individual? And how is the variability among individuals to deal with those stressor experiences and the stress responses it yields? Mm-hmm. And I think that's a really difficult question, but I think we are in a phase of life where we can examine during daily life more and more what is going on in an individual's life, and that is partly due to the development of technology and the fact that people walk around with a mobile phone, for instance, 24/7, or that we have effective wearables that can detect a person's behavior in normal life. So we want to really examine stress, and we can talk more about the terminology of stress, what is stress, later on, but we want to understand what stress does in a daily life. And I think this is relevant for health overall, not just for mental health, but obviously it is also important for mental health, but also for lots of other health conditions. We know that stress exposure, so think about work stress, or think about work-life balance, or think about experiencing stress due to poverty or due to discrimination, has shown to lead to all kinds of health outcomes, not just mental health outcomes, but also cardiometabolic conditions, for instance, or pain conditions or cognitive diseases. So stress is really important for understanding the impact on health outcomes. And I think we need to better know and understand what stress does in a daily life context to really be able to better deal with learning people how to better cope with it, and how we can really help people with facing their stress and their stress impact.
Yeah, so the first step is to first describe what it is, because I guess stress is a very heterogeneous concept. I think it's also a very personal concept. I find it funny when I ask friends or family, or like, yeah, what do you think stress is? I'm in this project, stress in action. And people really quickly go existential, for instance.
Yeah.
At least on me, they say, oh, stress about the future. And I think it's funny.
Oh, it's really crucial what you're saying there. I think if you ask 20 people what is stressing them, you get 20 very different answers. And I think that is the reality, right? What is a stressful experience for me? Maybe, a healthy circumstance that you thrive well on for you, right? So I think it is very individual, and that's partly because it depends partly on your coping or on your personality or on your even your biological and genetic makeup, how you're dealing with a stress exposure and what stress response that gives for you.
Well, this is what I enjoy most about this kind of work, like incorporating cognition, behavior, emotion, physiology, because, well, it's so personal, and I feel it's so big. Like, life is happening everywhere all at once, right? We're trying to track everything. But I think what I like most about this is that the first step is that, okay, now we realize everything is happening. All these things are connected. At least let's become aware of that and see how it works out. And then we have some technologies that can help you track. And then maybe in the future we can go to prediction of disease, right?
Yes.
See when it can happen. Do you think that's a feasible goal, to actually predict when a tipping point is going to happen? Or
well, I think it's a huge goal, but I think we need to give it our best attempts to add to this stress research. So I think you're right. We want to know better how we can measure daily life stress exposure as well as stress response within an individual during, days or even months in normal life. We want to see to what extent we can use measures of those daily life stress experiences and responses to predict disease. But we also want to see to what extent this is individual based, and maybe there are some denominators that are common for everybody, right? So certain stress experiences may be more shared than others. And we also want to, and this is during the later part of the project, we also want to learn what are then triggering signals that we can use to either inform people, like, hey, you're experiencing this, maybe you should consider, reducing this certain activity, or think what's going on, and maybe you can deal with that. So really alert people, but also work on tools that we can offer people to cope with stress conditions and even reduce their stress.
Yeah. Well, in the end, technology here plays a huge role, right?
Yes.
Because that's what we're trying to use, all these wearables and smartphones. That are constantly measuring us. And I have sometimes this weird feeling that I wanted to ask you about. Maybe you shared, maybe you don't. But when we think about an alert that is just being sent to people because we're being tracked, and now it's like, okay, the phone just says you, hey, you're experiencing this. How do you see that in relation to, for example, stopping and paying attention to what's happening with yourself in your body? Why do you think we need to rely on the technology, or how can it actually help us?
Yeah, well, I think it's a very good question. I think we need to be aware that monitoring and triggering people can actually be more stressful than stress reducing. I think that's what you're referring to. So I think it's very important to involve very strongly the user perspective. And I think in the Stress and Action Project, we have several groups that really are expert in doing that. We not only need to develop tools that are technological possible, we also need to have tools that are valuable by the users and that are feasible to use. So this is something that is part of the project, that we incorporate persons' perspective on this. And also here, I don't think we will find one tool that fits everybody's needs. I think even here we need to be flexible and adapt to a person's expectations and preference. So it may be that a certain tool that considers or triggers certain signals when a person's experiences, for instance, an extended increase in heart rate, and we see that also the effect is dysregulated and that there's more negative emotions, for instance, at that time, which may be an indication of a stress experience. That warning a person when that happens, for some people, really will be beneficial, because some people then may take the step back, like you mentioned, and think, can I change my behavior? But for other people, this may not be very beneficial, and they may be stressed by it. And I think we need to learn about that as well. And this is part of the project, to involve bigger groups of users to talk about these issues. And I think it's also not realistic to think that we can develop tools that work for everybody. And that's the same as for the current treatments we have, right? And there is no intervention that we can do that the entire society will respond to in a similar way and reduces all stress. So I think we really should be clear on what to expect.
Yeah, indeed. And also clear on what to avoid, because sometimes I feel with all this world of data, there's kind of this data fetish. And then it's like we rely more on the data to tell us something about ourselves than us. Or, for example, the doctor, right? Like the doctor-patient relationship, I feel, is very important here. Like if someone is having a problem, and the data should be, at least for me, it should be like an intermediary to have a conversation. Like, look, this has been happening to me for the last month. Let's talk, instead of relying purely on the data. I think if we take it towards that direction, where it's a complement to the knowledge that we already have and not a substitute, then it can be really powerful. But sometimes I'm afraid with how the world of big data is happening. Maybe that's another question that I have for you.
Yeah, right? And I think it's right. I mean, I think the really a big question, an important question, is what is the noise level out of all what we can measure these days? And can we truly isolate a relevant signal out of all the noise signal that we are collecting too? And I think that is really a crucial question. But I think it's a very important question to ask, because we will learn from it. And this is not a field where in 10 years we're done. I mean, we know technology develops more and more things we are able to measure, to follow in a person's individual's life. I mean, there are now ways of listening to speech interpretation of text, for instance. We can look at signals of typing speed or typing errors that people make that may say something about our cognitive state. I mean, there are all kinds of subtle signals in the world around us that do say something about our state of mind. However, there are also lots of noise systems that interrupt some of these signals, because, slow typing can simply also mean that you're typing while walking. So we really need to be incorporating multiple signals and really ask the very critical question: are we measuring noise or are we measuring true signal? And what is then the most true signal? And I think that is one of the core goals of Stress and Action Project.
Yeah, that sounds really interesting indeed. Yeah, I'm also wondering, given, like, for example, we're working more in a clinical setting, I would assume, and big tech companies, for instance, already have so much data, right? So I was wondering also how we distinguish ourselves from from these companies that have been doing this for years, right, and use it for other purposes. So yeah, how do we see our relationship with that?
Yeah, I think that's an important question. Indeed, it's not easy to compete to Apple or Google or big companies that are also tracking people during their lives, and those companies are also very interested in the stress field. I think, and they sometimes already come up with products that have not been evidence based, and I think that's really where a big difference is. Or maybe it is evidence based, but at least they don't share with the rest of the world what their evidence is. And I think this is really a difference in research that we want to make. We want to be really clear and open about the tools. We want to validate them. We want to have an evidence base to everything we do. And I think that is what is a difference with some of the tools out there, which came from a commercial point of view, but not from a scientific driven point of view. That doesn't mean that they may not be adequate, but I think in academia, we really want to first see the proof of the pudding that certain tools really work and really reflect stress response, which I think is a different starting point than lots of the commercial organizations. Ideally, we have in Stress and Action, we are setting up a validation pipeline as well. So where we are checking wearables, checking tools, and see do they really respond when people are experiencing stress. So we actually have a lab where people are exposed to stress tests, where we follow them for a few days and really monitor them carefully, so that we can really validate these tools and see do they truly pick up stress. So ideally, some of these bigger companies come to us and ask whether we can help them also with further validating tools that they may be developing.
Yeah, that's definitely interesting. Yeah, I'm also curious about the difference between cardiometabolic and mental health, like what these tracking technologies can do for each one. For a heart issue, for example, I imagine the use of a passive sensing that's continuously monitoring you and then detects a spike or something, and it's like, okay, alert. But with mental health, I find it so subtle and it's so integrated in your narrative experience of yourself that I wonder if you also have thought about how to differentiate tracking technologies for both of these experiences.
Yeah. Well, I think it's a very good question. So why am I very interested in mixing mental and somatic health? First of all, we know from huge literature that mental and somatic health are very correlated, right? So we know that people, for instance, with a depressive or anxiety disorder are at higher risk to develop cardiometabolic conditions. And we also know that people with cardiometabolic conditions are more likely to develop mental health disorders. So there is this bidirectional relationship between these different health outcomes. If you would ask me why that is, I think a crucial role exists for stress exposure and the stress response of our body. So if you think about the stress response of our body has certain stress systems. If you are experiencing acute stress, what happens is your autonomic nervous system becomes activated and becomes more sympathetically innerved, meaning that your body is placed in an activation state. And 15 minutes later, the HPA axis, which is also a stress system that is being activated, releases the stress hormone cortisol. And even later, if there is more chronic experience of stress, also your immune system becomes activated and produces higher levels of inflammatory markers. So these biological stress systems are very helpful for our body. They deal with acute stressors, and they make certain, for instance, if you have certain pathogens that you're experiencing, that your body deals with that and prevents you to become sick. But these stress systems also respond to more chronic psychosocial stressors. And if they do that in a very chronic, elevated state, they can actually be detrimental for your body and your brain. And this is what we know from research. An overactivation of these biological stress systems is actually linked to both a cardiometabolic condition, but also to mental health conditions. The brain and the body are in direct interaction. And even these biological stress systems with, stress hormone cortisols, they are directly relevant for brain function as well. So there are actually really shared pathophysiological mechanisms, really, from the stress biological system, allostasis, that are very relevant for all kinds of health outcomes. And so I do think it makes lots of sense to examine not just mental health, but also somatic health. And for the project, we chose cardiometabolic conditions because, like you mentioned already, the stress system dysfunctions like an autonomic nervous system activation or an HPA axis chronic activation, we know are very relevant for disease conditions like diabetes, cardiovascular disease, and obesity, for instance. So for me, as a scientist focusing a lot on the interaction between mental and somatic health, it makes lots of sense to not just look at one side of the coin, but look at both sides of the coins because they are impacting on each other as well.
Yeah, again, I'm coming back to like the idea of everything is happening all at once, and the challenge, of course, is measuring all of that. But what's the plan, or like how do you see integrating all these diverse data sources that are happening at a seconds level, minutes, months, years? How does that work?
Well, you're a PhD student working in this project, right? So you're going to contribute to that. But I do think, yes, you sketch the complexity, and I think that is the reality. I mean, some people consider stress as a vague term. I don't think it's vague. It's very complex. We have the exposure of stressors. We have the different stress responses, as you already mentioned, so affective, cognitive, behavioral, and physiological levels. And we have the time scale. And I think they are all relevant to really better understand and put evidence to the concept of stress. And that's what our intention is. We need to learn on how affective response interacts with biological response, and whether one is driving the other or whether they are truly bidirectional, whether one is a faster response than the other. So we really need to add the integration of these different stress responses, but also the time interaction to the picture. Is it simple? No, but I think we need to make steps to do so, and it starts simply with measuring, right? I mean, I think lots of research, if you just look at the research that looks at stress and cardiometabolic health outcomes, for instance, they are mainly focused on the biology. They don't really do much with behavior and affective stress response. If you look at the mental health field, then they're mainly focusing on the cognitive and the affective stress response, whether people are negatively responding with negative emotions, and whether they are worrying, and what their cognitive coping is when they are exposed to stressors. But there's hardly any incorporation of the biological response. So I think by merging the two outcomes and by merging the different fields of stress that are going on in these different health outcome fields, I think we get a more complete picture.
Yeah, well, this integration of mind and body measures is something that I think about a lot. And I wonder how to do it, right? Because sometimes I feel that science merely does correlations and says, okay, this is happening in your body, this is happening in your emotions, and just draw the correlation. But sometimes that still feels like there's a separation. Like what I really think is an integration of mind and body is when also the person pays attention to their experience and how having access to all their data transforms their experience of their body, of how they interact in the world. Maybe that's a more philosophical view of like mind and body integration. But I guess then also, like, what do you think about incorporating people's experience into science? usually science is like a third person perspective, right? But now, if we really want to know how everything comes together.
Well, I think we in stress research we cannot do without experience. I mean, if you ask me the question, what is stress? Then stress is really the lack of or loss of an equilibrium of the demands that a society places on an individual and the perceived ability of that individual to deal with that, right? I mean, in this definition, there is already the term perceived. And because again, what is stressful for one person is not stressful for another person. And I think also we know that even the biological stress response is not similar within persons when they are experiencing the same stressful situation. So that means that perception, but also coping of an individual is very important on how the impact of stressors is experienced, but also how the impact of stressors is leading to changes in behavior and in biology. So we can't do without perception in stress research.
Yeah.
That doesn't mean that we can't do a good job in measuring this, because we also can measure perception.
Yeah, but I think there's a difference between measuring perception from a third-person perspective, like self-report measures, right? We're just observers. We let people fill in a questionnaire. And I still think that's maybe not enough to really consider perception, like an in-depth interview of a person of how this data comes together. I feel that, makes more sense.
But I think that is also where I think we are heading to. I mean, we're not only measuring and monitoring to think that we as outsiders can give tools to people on how to deal with stress and how to cope with stress in a healthy way. I think we are mainly trying to help individuals to look at their own data and start a conversation based on that data that could be beneficial for that individual. So I think the person is central in understanding his or her own situation and his or her own coping strategy.
Yeah, indeed. Well, I guess this is what we'll talk about in this podcast. This is the first episode, but we're going to interview researchers from our group, experts in many different fields. People who are more focused on well-being, people who are more focused on the biological aspect of stress and on human-tech interaction. And hopefully the goal is to, help people navigate it and realize that, everything is happening all at once. We can try to measure it, but in the end, it's how you integrate it in your own identity and your own story and your own relationships and way of being in the world. I think that's what counts. And I'm very happy to be a part of this group, and I'm very happy that you were here today talking with us, Brenda. So stick around if you want to hear more about stress, technology, health, and being human. Thanks for listening.
Thanks for doing this, Marcos.